Good morning, guys. It's Trish Davis. I know you guys remember me from Tuesday Morning Lab. I am going to be with you guys today to teach you your addiction lecture. So this is actually one of my favorite topics. I love all the information that's in here. I think that this is very prevalent to what we see as nurses. The United States has a huge issue with addiction, not just the United States, other countries as well. It's a very prevalent issue. If you don't see it in the workplace, most people have someone in their family that suffers from addiction, or they have a friend or a friend of a friend. It's a very prevalent issue. And since you guys are going to be in the healthcare field, you can benefit from understanding and educating yourself as much as possible about addiction, because more likely than not, you will probably find yourself caring for someone who has an addiction to alcohol or drugs at some point. So let's get started. So let's just talk about a couple key terms. Intoxication. Most of us know what that is. It's just the use of a substance that results in maladaptive behavior. Then we have withdrawal syndrome. That refers to the negative psychological and physical reactions that happen when you stop using a substance or when you decrease the amount that you use. Then you have detoxification, which is the process of safely withdrawing from a substance. And then we have substance abuse and substance dependence. So you will hear these terms used interchangeably, but there is a small difference between the two. So substance abuse is when someone uses a drug that is inconsistent with the reason it was ordered, despite any negative consequences that can happen. And then substance dependence is the problems that are associated with addiction, such as tolerance, withdrawal, and unsuccessful attempts to stop using the substance. So substance abuse is, for example, if you have a patient that had a hip replacement surgery 3 months ago, they're not having any pain anymore, but they are addicted to the medicine. They take it in a manner that they weren't prescribed it. They take it because they're coping. They have something going on in their life. They like the way that it makes them feel. So they keep going back to the doctors and they keep saying, I'm in pain. My hip's bothering me. I need to have this medication. And then all of a sudden they're dependent. So they might not be taking the medicine every day to get high, but their body needs it because now they've built a tolerance to it. And if they don't take it, they'll go through withdrawal. And withdrawal can be really miserable. So they can have diarrhea, they can have nausea and vomiting, they can have headaches, they can have body aches, chills. Pretty much all the symptoms that kind of sound like the flu are symptoms that you get when you are going through withdrawal from a medication. So let's see. Next is just a couple fun facts. Like I said before, addiction is a national health problem. 15 million Americans suffer from some sort of addiction to drugs or alcohol. 500,000 of those people are between the ages of 9 and 12. That number to me is astonishing. 9 to 12 years old. That is so young. And then 7 million people in the world are said to binge drink or binge using drugs, and mostly between the ages of 12 and 20. Of adults aged 18 and older, 14% of them admitted that they binged during the last month. The actual precise prevalence of substance abuse is kind of difficult to determine because many people who meet the criteria for a diagnosis don't actually seek treatment. So these surveys are conducted to estimate the prevalence, are based off of patients that self-report data. So that's why it's not always accurate. Worldwide, 3 million deaths will occur every year from the use of alcohol. 3 million. Alcohol is a causal factor in more than 200 disease and injury conditions. And alcohol absenteeism due to alcohol is very high for employees who have alcohol-related problems, and they use more health benefits as well. 88,000 people die from alcohol-related causes each year, and alcohol-related death is the third leading preventable cause of death in the United States. With regards to motor vehicle accidents and fatalities, 30% of driving fatalities are alcohol-related. It costs $102 billion annually between lost days at work, accidents that happened in industrial settings, work-related settings due to alcohol or drug overdose, because employees are absent and because they get hurt at work and then they have workman's compensation claims. There's an increasing number of infants that suffer psychological and emotional consequences because they were exposed to alcohol or drugs when their mom was pregnant with them, such as they can have fetal alcohol syndrome or neonatal abstinence syndrome. Chemical abuse also, which isn't surprising, results in increased violence, increased domestic abuse, homicide, and then unfortunately child abuse and neglect. And it is believed that children as early as 8 years old have their first introduction to alcohol because their parents let them take a sip, or they think it's funny when they're babies. You know, they say, here, take a sip of this, because they like to watch them make an ugly face. So probably not too good to do that to your kids, but unfortunately, I know those things happen. So children of alcoholics are 4 times more likely to develop problems with alcohol. There is a huge genetic component that goes along with alcohol and drug addiction. Some people use alcohol because they need to cope. Some people do it and they don't even realize they're using it because they don't have the proper coping mechanisms. They use it to relieve stress and tension. It gives them a feeling of power. It decreases their psychological pain. Others think that even children who have great family lives when they were growing up still have unsuccessful relationships, that they have trouble building relationships, and that they don't have coping skills. And then, of course, there are the group of theorists who believe that children that grow up to have problems with addiction and alcohol, that it's centered around their upbringing, that they don't have a good relationship with their parents, or that their household was very dysfunctional, or that they were, only had one parent and the parent had alcohol related issues, or the parents weren't there for their kids. So there's a lot of different theorists that think different things. 50% of all traffic violations involve alcohol. 20% of suicide victims are alcoholics. More than 30% of alcohol deaths are considered suicides or related accidents involving alcohol. And about 60% of the variation in causes of alcoholism were the results of genetics, like we said earlier, with the remainder caused by environmental influences, such as peer pressure, drinking with friends at work, that kind of stuff. And then it said that some people just have an internal alarm clock that limits the amount of alcohol consumed. So I could go to the bar with some friends, and after 1 or 2 drinks, I'm just completely satisfied. And I don't have to go any further, but other people experience the high initially to continue, and they just have to keep drinking until they're intoxicated. Just 1 or 2 is not enough for them. All right, so like I said before, there are psychological factors that enter into whether or not someone will be addicted to alcohol or drugs. Coping mechanism has a lot to do with that. The feelings of power, related stress, family dynamics. They believe that there's an inconsistency in the parents' behavior, poor role modeling, a lack of nurturing along the way. We said this before, coping styles. Some people use alcohol to relieve stress and tension because they think that it helps them. Like I said, it increases their feelings of power and it decreases their psychological pain. But in reality, without them realizing it, the high doses of alcohol actually increases muscle tension and nervousness and gives them bad side effects. And then we have cultural factors. So all influence initial and continued use of substances. In general, younger people experiment with substances that carry less social disapproval, such as alcohol and cannabis, while older people use drugs such as cocaine and opioids that are costlier and rate higher disapproval. Many believe that although illegal in some states, the use of cannabis is not as harmful as other drugs. Then we have cultural considerations. So Certain ethnic groups have certain genetic traits that either predispose them or protect them from developing alcoholism. For example, flushing, which is a reddening of the face and the neck, comes as a result of increased blood flow, which has been linked to variants of genes for enzymes involved in alcohol metabolism. Even the smallest amounts of alcohol can produce flushing, which could be accompanied by headaches and nausea. And this flushing reaction is highest among people of Asian ancestry. The Japanese, they do not regard alcohol as a drug at all. There are no religious prohibitions against drinking. Excessive alcohol consumption is widely condoned at parties, business functions, and at home, and it said that they have an enzyme that rids their body of alcohol faster than other ethnicities. Muslims don't drink alcohol at all, but wine is an integral part of the Jewish people's religious rites. Some Native American tribes use peyote, which is a hallucinogen, in religious ceremonies, so it's always important that as nurses we're aware of the beliefs of our patients when we're assessing them for a substance abuse problem, because we wouldn't want to accuse someone of abusing a drug that they use every day in a religious ceremony. Some Native Americans, let's see, I'm repeating myself, sorry about that. Statistics for individual tribes vary, but alcohol abuse overall plays a part in the 5 leading causes of death for Native Americans and Alaskan Natives, which are motor vehicle crashes, alcoholism, cirrhosis, suicide, and homicide. Among tribes with high rates of alcoholism, an estimated 75% of all accidents are alcohol-related. 1/8 of Native Americans are identified as needing treatment for alcohol and drugs. Most commonly, methamphetamine and marijuana, those are their drugs that they abuse. And Alaska Natives are 7 times more likely than the general population to die of alcohol-related problems. And also, when we talk about the Russian ethnicity, male Russians have a higher rate of alcohol abuse, suicide, smoking, accidents, violence, and cardiovascular disease. All right, so we talked about alcohol and we talked a little bit about drugs. So there's different kinds of drugs that people can experiment with. So you have hallucinogens, which are substances that actually distort the user's perception of reality, and they produce symptoms that are similar to a psychosis, including hallucinations, which can be visual, and depersonalization. Then you have amphetamines, which are stimulants. These were first used to treat psychiatric disorders in the 1930s because they have a huge pronounced effect on the CNS stimulation system. Today, they're used a lot for ADD and ADHD, and these are drugs that are abused every day. Then there's marijuana, which we all know in some states is legal, in some states it's not. It is considered a mind-altering drug. And then you have barbiturates, which are central nervous system depressants. So they reduce the activity of nerves, causing muscle relaxation. Then you have tranquilizers, which are agents that suppress or inhibit some aspects of the central nervous system, and they're referred to as what we just call CNS depressants. They're used primarily to treat insomnia, as well as a wide variety of other anxiety disorders. And then some physiological symptoms that you see with these medications would include the patients would be sweating, they could have tachycardia, they could be experiencing heart palpitations, they could have blurred vision, tremors, and a lack of coordination. So the consequences of taking these drugs, there's a wide range of mood and effects that are possible on the body. Some clients are sad and tearful. Others express guilt and remorse for their behavior and their circumstances. Others may be angry and sarcastic, or just quiet and withdrawn and completely unable to talk to the nurse or family members. Irritability is a pretty common side effect to see because clients are newly free from substances. And when they don't have the medication that they need in their body, it causes them to be irritable. Clients could be pleasant and seemingly happy and appear unaffected by the situation. especially if they're in denial about having a substance abuse issue. All right, so categories of drugs. So we have alcohol, we have sedatives, hypnotics, and anxiolytics. We have stimulants, cannabis, opioids, hallucinogens, and then inhalants. So let's talk a little bit more about those. So alcohol. So a laboratory blood alcohol level of 0.08 is considered legally intoxicated for any adult that is operating an automobile. Alcohol is a central nervous system depressant. It's absorbed rapidly into the bloodstream. Initially, the effects that you see are relaxation and loss of inhibitions. With intoxication, there can be slurred speech, they can have an unsteady gait, a lack of coordination, impaired attention, concentration, memory, and judgment. Some people become aggressive or display inappropriate sexual behavior when intoxicated. The person who is intoxicated may also experience a blackout and then the next day not remember anything that happened. An overdose or excessive alcohol intake in a short period can result in vomiting, unconsciousness, and respiratory depression. The combination can cause aspiration pneumonia or pulmonary obstruction, and then it leads to alcohol-induced hypotension, which can lead to cardiovascular shock and death. So alcohol dependence. Alcohol, like we said before, is a central nervous system depressant. It's absorbed rapidly into the bloodstream. The effects of alcohol can be chronic, which means it goes on for years, it's continuing, it's progressive, and eventually it's a system-wide disease that's seen throughout the body. And left untreated, many of the diseases that can develop in the patient can be fatal. Patients suffering from alcohol dependence usually deny having a problem, which leads them to have an increased consumption of alcohol. The increased consumption then leads to alcohol tolerance, which requires them to consume more alcohol to then get the desired effect. Alcohol tolerance can also cause a cross tolerance for drugs, which means that they have a higher tolerance level than normal and require higher amounts of medications. Symptoms include hand tremors, sweating, elevated pulse and blood pressure, insomnia. A lot of patients will be anxious, they'll be nauseous, they'll be vomiting, and then severe or untreated withdrawal may progress to hallucinations, seizures, and delirium. Statistically speaking, women do present with health-related issues related to alcohol consumption sooner than men. And there are theories on dependence, like we said earlier, can be genetic links to alcohol and family dynamics. Children are 4 times likely to develop alcohol, and inconsistency in the parents' behavior, poor role modeling, and lack of nurturing pave the way for a child to adopt similar style of maladaptive coping and substance abuse. All right, so the cycle of alcoholism. The first episode of intoxication happens, then they continue, they have continuing problems with alcohol, then they have their first blackout, they continue drinking, then they develop a tolerance to the alcohol, which means they have to continue to drink more in order to get the desired effect. Then they have what's called a tolerance break, which means that a person who drinks heavily gets intoxicated on a very small amount of alcohol, which seems kind of weird that after they built this tolerance that they would only get drunk off of like a little bit of alcohol, but that's what we call a tolerance break. Then they continue drinking, and then they can actually be functioning. They can be functioning for an extended period of time, but then eventually they're going to be absent from work. It's going to cause problems. They're going to end up in crisis. And then it's just a continuous cycle. It just goes on and on and on. So symptoms of withdrawal usually start within 4 to 12 hours after their last drink. They peak on the 3rd day, and usually after 5 days, the withdrawal process is pretty much done. Like I said before, symptoms include sweating, hand tremors, elevated pulse, blood pressure, trouble sleeping, anxiety, nausea, and vomiting. Left untreated, you're going to have those hallucinations, the tremors, the seizures. However, in some people, withdrawal can take 1 to 2 weeks. So you'll see in the hospital setting, if you have a patient that comes in and they're on alcohol withdrawal, you are putting certain things in place. You know, they're going to be a high fall risk because they're not going to be probably stable on their feet. You're going to want to pad the side rails because they are at risk for having a seizure. Things like that. So usually when a patient detoxes from alcohol, they have to be, it has to be done under medical supervision because unlike other drugs, alcohol withdrawal can be life-threatening. So if the client's withdrawal symptoms are mild and he or she can abstain from the alcohol, they can be treated safely at home. For more severe withdrawal, for patients who cannot abstain from drinking, or for patients that have been drinking for so long and drink so much, you really want to have them in the clinical setting. It's a very short admission of 3 to 5 days. So that way you can monitor their symptoms, and then you give them medication to help with their symptoms, and then you do it safely so that they don't have any adverse side effects. So safe withdrawal is usually accomplished by administering them benzodiazepines. So we give them Ativan, we give them Librium, we give them Valium, and what they do is they suppress the withdrawal symptoms. So what usually happens in the clinical setting is they come in and we put them on something we call CIWAS. CIWAS. So that stands for the Clinical Institute Withdrawal Assessment of Alcohol Scale. So it looks at a couple different things. It looks at your blood pressure. It looks at your pulse. You have to look at the patient and see if they have any tremors. Are they sweating? And then you ask them questions like, do they have any auditory disturbances? Do they have any visual disturbances? Do they have a headache? You can ask them if they feel anxious. Do they have any numbness or tingling in their hands or feet? And then for each question that you answer, it gives us a number for each one that you choose, and then you add it up, and based upon the number that you get, you'll have a order set in your MAR that coordinates to the amount of medication that you would give. So it might say to administer Ativan 1 milligram for a score of 7 to 9, administer 2 milligrams of Ativan for a score of 9 to 15, and so on and so on. So there will always be parameters in the computer after you do the score to determine what type of medicine you're going to give the patient. Usually the doctor determines the frequency that you're going to do the CIWAS. It's usually every 4 hours. Sometimes it's every 6 hours as they get further out from their last drink and they're starting to do better. But the standard is usually 4 hours. All right, so some nursing diagnoses for patients that suffer with alcohol dependence. So you have dysfunctional family process related to the abuse of alcohol. You have insomnia related to the effect of alcohol withdrawal and anxiety. You have anxiety, which makes sense, related to situational crisis and withdrawal. You have acute confusion related to the effects of alcohol withdrawal. You have imbalanced nutrition, less than the body requirements related to poor dietary habits, plus they're not able to absorb vitamins as well because of the alcohol, so that puts them at risk for imbalanced nutrition. Then chronic low self-esteem related to repeated unmet expectations. They might be really down on themselves because they've tried to be clean before and stop drinking and they haven't been successful. Risk for deficient fluid volume, risk factors because they're sweating, because they're going through withdrawal. They have decreased fluid intake because they don't feel good and they're sleeping, so they're not drinking. So just some nursing considerations. Like we said before, you need to remember that this can be life-threatening. Patients can die if they're not treated properly during the withdrawal process. You want to provide for seizure precautions. You want to make sure that they have a high fall risk sign on the door so that anyone that comes in knows that this patient's at risk for falling. You want to make sure they have on their red socks, their red bracelet, put those seizure precaution pads on the side of the bed rails in case they do have a seizure, they don't hit their head and hurt themselves. You're going to monitor their vital signs and their neurological status, right, every 4 hours. And you're going to administer medications as ordered, scheduled, or PRN, like for your CIWA, maybe you're going to give some vitamin replacements, things like that. All right. So alcohol dependence. Complications, of course, come along with anyone that has a dependence to alcohol. It can be impaired memory. You could have a stroke. You could have metabolic deficiencies. You could have cardiomyopathy. You could have neurologic disorders. And then, of course, if you're pregnant, then your baby could suffer from fetal alcohol syndrome. So portal hypertension is an increase in the blood pressure within a system of veins called the portal venous system. Veins come from the stomach, the intestine, and the spleen and the pancreas. They all merge together into the portal vein, which then branches off into smaller vessels, and it travels through the liver. If the vessels in the liver are blocked due to liver damage, the blood cannot flow properly through the liver, and as a result, high pressure in the portal system develops. Signs and symptoms of portal hypertension could be a GI bleed. They may have ascites. Ascites is a very swollen, distended abdomen. They might look like they're pregnant when they're not. They could have encephalopathy, and they can have decreased platelets. Patients can also have esophageal varices, which are dilated, bulging esophageal veins. These can be dangerous. If they rupture, they could potentially bleed to death. So diagnostic findings that you would want to look for, you want to check your blood alcohol level of your patients. You want to do alcohol toxicity levels. You want to check elevated liver enzymes because they're probably going to be elevated due to the increased alcohol intake, and then also pancreatic enzymes because they reflect alcohol-induced liver disease as well. Oops, sorry about that. Didn't mean to move that. So let's see. We said that patients can have cardiac myopathy. They can also have something called Wernicke-Korsakoff syndrome, WKS, which is one name for actual two conditions that usually happen together. So Wernicke encephalopathy and Korsakoff syndrome. So many doctors think of them as different stages of the same disease, and symptoms include confusion. Patients don't know where they are. They don't know who they are. They have trouble eating, holding a phone. They have loss of muscle coordination. They can't do things that they could normally do for themselves. They may report trouble with their vision. The Korsakoff syndrome usually happens more slowly. It's a long-term ongoing problem that damages part of your brain that handles your memory. You can also have esophagitis, hepatitis, cirrhosis. I'm sure you guys have heard of cirrhosis of the liver. Left untreated, that can turn into cancer. Leukopenia, thrombocytopenia. Let's see. All right, so in treating alcohol dependence, it's really important to undergo detoxification. Like we said earlier, because death can result. They are at a very high risk of having seizures. Clients being treated for intoxication and withdrawal are encountered in many, many different types of settings. So you can have emergency rooms. It can happen in psychiatric departments. There can be outpatient clinics that just do alcohol withdrawal, and then some clinics at all, they don't want to treat patients that are detoxing from alcohol because of the high risk of them having a seizure and possibly dying because it is so dangerous. So a lot of the treatment centers won't take you until you're actually detoxed from the alcohol. So you'll have to go to the hospital or you'll have to do one of these quick 5-day programs. That can be challenging because those programs fill up quickly, especially now with COVID. This is a huge problem we're seeing. Patients can't get beds because they're only filled at partial capacity because of COVID. So what they do is they medically detox, and then when they're ready, they will go into some type of a treatment program once they've actually been detoxed. We talked about nutritional deficiency, so it's important to include these in your plan of care. So you're going to give fluids and vitamin replacements. Alcoholics neglect their food intake. They drink a lot and they don't eat or they pass out and they're not worried about their diet. You know, they come home from work, they start drinking, and technically they view that as their dinner. So their nutritional intake is not good. They eat less food than they need, or instead they get the bulk of their calories from the alcohol. Alcohol contains none of the micronutrients that are essential to health, and inadequate food intake on its own can lead to a lot of nutritional deficiencies. The second reason that alcohol reduces the body's ability to extract nutrients from food. And over time, heavy consumption of alcohol damages the lining of the GI tract, which interferes with the body's ability to absorb any kind of nutrients. As well as this, chronic alcoholism causes the body to excrete higher than normal amounts of certain nutrients. So for alcoholics, they are serious risks of deficiency in multiple nutrients, and the risk is greater in people who eat less food as a result of drinking. So patients should receive medication for their withdrawal symptoms, psychological therapies. You want them to foster successful rehabilitation. You want to encourage them to take their medication. Most patients that have problems with drinking have a lack of coping skills. So it's really important that after you detox them and they go into a treatment program, that they get therapy so that they can try to determine why it is that they have a lack of coping skills. What happened in their life that they got to this point? Getting to the bottom of those problems will help them have a better understanding and will help them to eventually make different choices in their life. So there are different drug therapies you can give. So you can give something called Antabuse, which is prescribed to help patients deter them from drinking. So what happens is they take this medication, and then if they drink alcohol, they're going to have a severe adverse reaction, which can be flushing, a throbbing headache, they can be sweating, they'll have nausea, they'll have vomiting. In severe cases, it can cause severe hypotension, confusion, coma, and even death. So if they take this medication and then they decide to drink, they're going to regret it, and hopefully they will remember that feeling and they won't do it again. You can take something called acamprosate or Campril, which helps the patient's cravings for alcohol decrease, and then the physical and emotional discomfort that occurs from not having it within the first couple months. Patients that are in treatment, you want to advise them to avoid any products that contain alcohol, such as cough syrup, aftershave lotion, mouthwash. These can all be used abusively. And then a lot of people they need to have a support system. So what better way to give these patients support than to refer them to a 12-step program, which is filled with people who come from where they do. They have a dependency with alcohol or drugs. So these 12-step programs are available in a variety of community settings. There's AA, which was founded in 1930s. It's a self-help group that they developed a 12-step program model for recovery. You can look at this in box 19.3. It lists all the steps. It's based on the philosophy that total abstinence is essential and that alcoholics need the help and support of others to maintain sobriety. Their slogans reflect the ideas in their 12-step program, such as one day at a time, easy does it, and let God and let go. So they do believe in a higher power. They believe that you give all of your problems over and let the higher power, have trust in the higher power, that they're going to help you get through another day and that they'll help you with your recovery. You can find meetings in churches. The majority of them are actually in churches. Sometimes they're just at community centers, but there is a lot in every community. There's actually a book that you can get. You can go online to find any kind of a meeting. It's a very welcoming group. It is anonymous, like it says, so everything that happens in that meeting stays there. You don't have to worry about anybody, posting your picture in any type of a setting, and anybody that you didn't want to know that you were suffering with a problem with alcohol, being able to find out. So it's actually a great program, and a lot of people have a lot of success with it. So we talked about alcohol. Now we're going to talk about sedatives, hypnotics, and anxiolytics. Again, these are CNS depressants. So you have benzodiazepines, for example, diazepam. Alone, when taken orally, are rarely fatal, but a person can be lethargic and can appear to be confused. You have barbiturates. These medications are most frequently abused in this category. The intensity of the effects depends on the drug that was ingested. So symptoms of intoxication are similar to those of alcohol, which include slurred speech, impaired attention, unsteady gait, a labile mood, coma, stupor. An overdose can possibly be lethal. They will have respiratory arrest, cardiac failure, and then death. So treatment options for people who abuse these type of drugs include a lavage, which is simply they wash out a body cavity such as the colon or a stomach with water or a medical solution, followed by an ingestion of activated charcoal and a saline cathartic. So saline cathartics are inorganic and they're poorly absorbed salts. So when you put the salt into the intestinal lumen, osmotic pressure increases, which pulls the water toward it and creates more bulk. And when you get more bulk, we have increased motility and peristalsis takes place. And it will rid your system of the drugs that you took. They work very fast in a matter of 30 minutes to 3 hours. If that's not successful, sometimes the patient has to go on dialysis. So they remove the blood, take all the bad stuff out of the blood, and return the blood to the patient. Some of the drugs that you guys have probably heard about are in this category. The date rape drug, that's definitely falls under this category. Let's see. All right, so the effects of intoxication, again, drowsiness, sedation, agitation, slurred speech, uncontrolled motor activity, disorientation, nausea, vomiting, respiratory depression. The withdrawal, how long it takes to withdraw can depend on the half-life of the medication. The withdrawal manifestations are the opposite. The symptoms will withdraw are the opposite of the acute effects of the drugs when the patient took them. So instead of the drowsiness and sedation, you're going to have insomnia and anxiety. You're going to have sweating. You're going to have hypertension instead of hypotension. There's possible psychotic reactions that you could have. The patient could have hand tremors, nausea, vomiting, hallucinations, psychomotor agitations, and seizures. So basically what you do is you treat the withdrawal symptoms. You can give lorazepam. Lorazepam lasts about 6 to 8 hours, so you're going to know that you have to keep reassessing your patient every 6 hours once those symptoms reappear, and you might have to remedicate them. But if the patient gets diazepam, that might not produce symptoms for up to a week, which is great. Gives the patient more comfort. Detoxification from sedatives, hypnotics, and anxiolytics is often managed by tapering the amount of drugs that the patient received over a period of days a week. So drug tapering is essential when patients are withdrawing from barbiturates to prevent coma or death. So you might get Valium 10 milligrams once a day and then decrease that every 3 days. So in 3 days, maybe you're going to take 5 milligrams, and then 3 more days, you're going to take 2.5 until eventually you're not taking any. So a gradual taper. All right, so stimulants like amphetamines and cocaine. So these are, they're different than the last set of medications that we talked about that were CNS depressants. These are CNS stimulants. So they stimulate or excite the CNS system. So you have amphetamines, which are also known as uppers. Back in the day, they actually still are, they were used to lose weight or to help people stay awake. An alternative to them, cocaine produces similar effects. There's methamphetamine, which is highly addictive and can cause psychotic behavior. It can cause brain damage due to the substances that are actually used to make it. They actually use liquid agriculture fertilizer to make this. So you can imagine the effects that would have on your brain if you are smoking that or snorting it, however they take it. There can be mild toxicity, such as dizziness, irritability, tremor, and blurred vision. More serious effects, you're going to have hallucinations, seizures, extreme fever, tachycardia, hypertension, possibly cardiovascular collapse, and then death. Seizures can occur, comas. These medications give a high or a euphoric feeling. They cause hyperactivity, hypervigilance, a lot of talkativeness, repetitive behavior, and in some people, even anger. And then the physiologic signs can be tachycardia, elevated blood pressure, and like I said, chest pain, maybe some chills, dilated pupils, cardiac dysrhythmias, and then even death. So withdrawals from these medications, the amphetamines or the cocaine, withdrawal occurs within hours to several days after stopping the drug, and it's usually not life-threatening. Dysphoria is the primary symptom, fatigue, vivid and unpleasant dreams, insomnia or hypersomnia, increased appetite, psychomotor retardation or even agitation, some depressive symptoms, including suicidal ideations that can last up for a couple days. Then always there's that possibility of seizures or coma with an overdose. And then stimulant withdrawal is not usually treated pharmacologically, but you can give Thorazine, which is an antipsychotic that helps control the hallucination. It can also lower the blood pressure, and it helps to relieve the nausea. So the effect that it has on the central nervous system, it produces extreme pleasure, the euphoria, increased energy. The cocaine forms come in powder. They can be snorted, dissolved, or injected. Crack is basically a purified form of cocaine. You can mix it with tobacco, marijuana. You can freebase it. Your methamphetamine, you can combine it with over-the-counter medications, chemicals. You can smoke it or you can inject it IV. It's a very intense physical experience. It's rapidly metabolized in the system, and cravings reoccur as soon as you don't feel it anymore. So as soon as you stop taking it, you go right away into having cravings to have more. Let's see. All right, so some assessment findings, signs and symptoms you're going to look for in your patient. As we stated on the previous slide, anxiety, they're going to be irritable and agitated, mainly because they want more of the drug and they're not happy about it. And they feel like they have to have it. They become paranoid. They're worried that someone's after them. People are watching them. Paranoia is a real side effect that you see in these, and it can be very scary for you, scary for the patient. They can have accelerated heart rate. They may not feel like eating. They'll be very restless. They won't be able to stay in bed, walking around. The signs and symptoms that you see usually correlate to the route of administration and how chronic their abuse is. So for patients that snort cocaine or crack, they're going to have ulcerations of their nasal mucosa. They may even have a perforation of their nasal septum. For patients that inject, they're going to have needle marks on their arm. They can have fresh needle marks. They can have bruising on their arms. We call them track marks. If they smoke it or freebase it, they could have burns. They could have a chronic cough, and they can have pulmonary congestion, so they'll have issues breathing. Let's see. So why do patients get addicted to these medications? Well, like we said, they are stimulants. If we're talking about meth and cocaine, they induce effects by increasing the user's level of dopamine. So dopamine is a chemical neurotransmitter that regulates the pleasure centers of the brain. It's involved in reward, motivation, and the experience of pleasure, motor function. Cocaine lengthens the dopamine actions, which means that it prevents the brain from reabsorbing dopamine, allowing it to accumulate in the synapses to induce an elevated mood and an increased sense of energy. Methamphetamine use blocks the reuptake of dopamine, but it also increases the release of the neurotransmitter, essentially producing a surge to the synapse. So to comprehend just how much dopamine meth releases and what it takes so rapidly and why it's so dangerously addictive, I'm just going to give you some numbers on how they compare. So both nicotine and alcohol cause dopamine levels to spike from 100 units to 200 units, okay, when they measure it. So if you're addicted to nicotine, and you have occasional alcohol use, your dopamine levels when you use those products will go from 100 to 200 units. In a person who uses cocaine, it causes a comparable higher release of dopamine. So it increases levels from 100 to about 350 units. And then when a patient uses meth, it boosts the dopamine from a baseline of 100 units to roughly 1,250 units, over 12 times that amount of alcohol or nicotine. So this shows you why these medications are, in fact, a disease process, and why patients are so addicted to them and why they keep going back for more. All right, so complications from long-term abuse of cocaine and methamphetamine. You can have anorexia because you're not eating. It takes your appetite away. So a lot of these patients are very unhealthy, very skinny. They have memory impairment. They can't remember what they did 10 minutes ago. Some can't remember what they did 2 days ago. They have the weight loss. They have behavioral changes. They're paranoid. They see things. They hear things. Hypertension, seizures. They're at risk for a cerebral hemorrhage. They could have a heart attack. They might have respiratory arrest. They can get something called cocaine bugs, which is where they just feel like things are crawling all over them at all times. This also happens with heroin. People will have sores all over their face. They'll have sores all over their arms, over their legs, because they're constantly scratching. And you're going to see a lot of withdrawal symptoms in newborns. So other risks that come with methamphetamine risk, they're at a higher risk for contracting HIV and hepatitis because they reuse dirty needles or they share contaminated paraphernalia with other people. When people are on the streets and they're trying to get their next high, they absolutely do not care if they use a contaminated needle or if they use one that they find on the ground. They will reuse it and they won't even think twice about it because they're only worried about getting that next high. So some diagnostic findings, you're going to want to run blood panels. You're going to want to look at CBCs. You're going to want to look at the urology tox screens. You're going to want to send off urine to see what drugs they have in their system. Because they're not always going to tell you that they've taken things. They'll tell you, no, I've never used drugs, or no, I haven't used cocaine in a week. And then you'll send their urine off and then it'll come back that they have all these drugs in their system. So they're not always honest and upfront with you. And then when they're withdrawal, they're going to be depressed. They're going to be tired. They're going to be craving. They're going to be really tired. They're going to have dramatic, unpleasant dreams, and they're going to have some psychomotor retardation and then some agitation. All right, so how do we manage these patients? So we want to get them into a rehabilitation program, which, like I said earlier, is a little bit more challenging than it used to be. It was always a little bit challenging because there's a huge need for these services and we just don't have the community needs right now to meet the needs of those patients, the community resources rather. And now due to COVID, the resources that are out there are actually taking less people because they can only take a certain amount of people. If they used to have 50 beds, now maybe they only have 30 because they can't keep people so close together. So it's a real issue. But ideally, you're going to refer them to AA, to NA. You are going to encourage them that they get some group psychotherapy. They can participate in outpatient, we call it IOP, which is intense outpatient program where they go every day for like 4 to 5 hours. They get treatment, they get their medication, they see a therapist, they are, have to attend meetings. It's a great program, helps keep them on track. So from the nursing perspective, you're gonna monitor their vital signs. You're gonna wanna keep the patient safe, implement those seizure precautions, make sure they have fluids, and allow them to rest and sleep. They're gonna be exhausted. They are not gonna want to sit up and watch TV. The effects that it has on the body are overwhelming. So allow them to have time, advocate for them. If PT wants to come and they want to do this test and they want to do that test, obviously these things are important, but try and chunk them all together, and advocate for them that they get everything done in the morning or, so that they have time to rest in the afternoon, or allow them to have time to rest in the morning and then schedule their things for the afternoon. You would want to administer any prescribed medications to the patient, and then you want to provide education. Education is a huge part of nursing. So you want to educate the patient and you want to educate their family members as well, because their family plays a huge role in them being successful, you know, in any type of a treatment program. All right, so now let's talk about cannabis, otherwise known as marijuana. It is used for its psychoactive effects. It produces euphoria, sedation, hallucination, and increased appetite. It lowers your inhibitions, and some people say it just causes them to relax. The effects of it begin to act in less than a minute after it's inhaled. The peak effects usually occur within 20 to 30 minutes, but it can last in some people up to 2 or 3 hours. Most oftenly, it's smoked in cigarettes or joints, but it can be eaten. You know, some people put it in food, brownies, things like that, cookies. Research has shown that cannabis can lower intraocular pressure, which is something that you see in patients that have for glaucoma, but it hasn't been approved yet for the treatment of glaucoma. It can relieve nausea and vomiting associated with cancer, chemotherapy, anorexia, and weight loss from patients that have AIDS. So you can give them Marinol or Sesament, and it can help increase their appetite, because patients that have chemotherapy don't have much of an appetite and they lose a lot of weight. And then patients also suffering with AIDS, they have a weight loss too. So this can help stimulate their appetite and get them a little healthier. Excessive use of marijuana leads to delirium or cannabis-induced psychotic disorder. Intoxication. So the effects of intoxication can be lung cancer. You can develop chronic bronchitis, increased appetite, dry mouth, tachycardia. You're going to see that elevated heart rate, inappropriate laughter, impaired coordination, and then you're going to see issues with their short-term memory. Withdrawal manifestations, they might be irritable, they could be aggressive, they could be a little anxious, they'll have trouble sleeping, they will not have any appetite at all, or a reduced appetite. They could be restless, they could show, have a depressed mood, they might complain of abdominal pain, they could have tremors, diaphoresis, fevers, and then headaches. So opioid dependence is defined, so we have opioid dependence and opioid addiction. Opioid dependence is defined as an increase in the need of opioid dosage to obtain optimum pain relief. Opioid addiction results in an increased consumption of opioids to maintain euphoric and erratic behavior. So, opioid dependence. Opioids are popular because they desensitize the user to both physiological and psychological pain, and they induce a sense of euphoria, or they make them feel very happy, and they give them a sense of well-being. Opioids are your synthetic narcotics. They sedate you after your initial euphoria, so you take them and you feel so great, and then after that, it just has a very sedative effect on the patient. They can be injected, smoked, or inhaled. The rate of tolerance and the chemical dependency ultimately is determined by the drug that you're taking, the dose, and how often they are taking it. So common drugs that you see that are abused can be morphine, Demerol, codeine, hydromorphone, oxycodone, methadone, oxymorphone, propoxyphene, heroin, and normethadone. The effects of intoxication that you're going to see on the patient, they're going to have slurred speech, they're going to have an impaired memory, their pupils are going to be constricted, their judgment or their social functioning is going to be greatly impaired. They're going to have decreased respirations, and they can have a decreased level of consciousness, which can ultimately result in death. So, assessment findings, signs and symptoms. So intoxication, like I said, you're going to have those pinpoint pupils. Patients can suffer constipation. Opioids have a very constipating effect. So even your patients who aren't abusing them, if they're just coming in because they had a surgery and you're giving them, you need to recognize that they can cause constipation. So you're going to want to maybe add on a stool. You're going to advocate for them to have the patient add on a stool softener for them. You're going to encourage them to drink a lot of fluids. You're going to get them up and moving. So constipation is something you're going to see. You're going to see respiratory depression, severe intoxication. You're going to see coma, respiratory depression again, pupil constriction, and even death. Chronic use of these drugs causes anorexia, constipation, malnutrition, needle marks, scarring. They can have cellulitis from using dirty needles. They don't take care of themselves. They don't take care of their skin. They can turn septic from these injections. That's a common finding you'll see when they come into the hospital. They come in with cellulitis because of injecting with dirty water, dirty needles. So diagnostic findings, what are you going to want to do? You're going to want to do a urine drug screen on these patients because, like I said earlier, they're not always upcoming with the information. They're not honest with you. As far as an antidote for these medications, I'm sure most of you guys have heard of naloxone or Narcan. This is a great medication. It works by blocking the action of the opioid that they took. It can be administered IV in the hospital or in nasal form in the hospital. I've never actually seen it given in nasal form in the hospital. I've given it twice, and the first time I gave it, I had to give a couple doses. The second time I gave it one time, and the patient completely woke up. They were right back to where they were. The medication was completely out of their system, and they were not very happy. One was an intentional overdose. The patient was trying to get high and took too much medication. One was that the patient was a downgrade to me, and they had given her too much medication along with some other medications that depressed her respiratory system. So she was not angry when she woke up because she didn't know what was going on, but the other person was really angry because basically they take that medicine because they want to get high. So when you give them the Narcan, it essentially takes away their high, and they're not too happy about that. So like I said, you can give it IV in the hospital. You could also give it in the nasal form. You see the nasal form a lot in the outpatient setting, like in the field, EMTs and people like just everyday people. Parents can give this medication to their children. If they have addicts that live at home, they should have some of this with them. And then in the field, it can also be administered into the bone. So EMTs can drill right into the bone and inject it that way. It works very quick. Within 1 to 2 minutes, the patient will open their eyes. The half-life is extremely short. You may need to give it a couple times every 5 minutes until you get the result that you need. And these kits are available to just the average lay people in the community, moms, dads, grandmothers, brothers, sisters, whoever feels like that they have someone that they come in contact with that's at risk for developing an overdose should have one of these and should take the training on how to use it. In the hospital setting, if you have a patient that does overdose and you have to use that and you're on a med-surg tele floor, you do have to understand that your patient will have to have monitoring in an ICU setting for about 6 to 8 hours. So that's pretty common that happens, and then they get upgraded to the ICU for a while because they require more monitoring. So this is just a little thing here to show you about the Narcan. Narcan is a narcotic antagonist, and an antagonist works the opposite way by blocking the receptor. So it's kind of like you have a keyhole and you jam glue inside of the keyhole. The medicine won't get through, okay? It keeps it from going through. So the Passero opioid-induced sedation scale, this is not a scale that I use in adult nursing. It is a pediatric scale that you can use. It is a validated tool that assesses the level of sedation when opioids have been administered. So basically, it is endorsed by the Joint Commission and the American Society for Pain Management, and it's to help prevent adverse opioid-related respiratory events. So you just look at this assessment tool and you basically score your patient however they're scoring. So if they're asleep and they're easy to arouse, you don't take any necessary action. If they're awake and they're alert and there's no action necessary, they'll get a 1. If they're occasionally drowsy but they're easy to arouse, they don't require any action, they would get a 2. If they're frequently drowsy and they drift off to sleep during conversation, then this is an indicator that you want to decrease the opioid dose, okay? And they would score a 3. If they're somnolent with minimal or no response to the stimuli, you want to discontinue the opioid and consider the use of naloxone. And that would be a 4. But like I said, this is usually used in the pediatric cases. I've never actually used that in a clinical setting. All right, so opioid dependence, medical management and rehabilitation. Withdrawal medications that we can give clonidine, we can give methadone. I'm sure you guys have heard of that before. Clonidine belongs to a class of medicines known as antihypertensive, but it's also frequently prescribed to help with the symptoms of opioid withdrawal. It works by blocking chemicals in the brain that trigger the sympathetic nervous system activity. It reduces uncomfortable symptoms of the detoxification from the opioids, such as sweating, hot flashes, watery eyes, restlessness, and it has been known to help lower anxiety and even cut off the detox time that it takes for the patient to detox from the opiate. For patients that have heroin addictions, they can use methadone maintenance therapy or Suboxone. So Suboxone comes in a pill form or a tablet, and it contains 2 ingredients. It's buprenorphine and naloxone. So buprenorphine acts as a partial opioid agonist, meaning it stimulates the same opioid receptors as heroin, but only to a certain point. The buprenorphine will have a ceiling effect. So the ceiling effect allows the drug to level off in potency at higher dosing levels. This mechanism acts as a safeguard by preventing a person from being able to overdose on the drug. And the second part of the drug, the naloxone, that's the second ingredient. It works to reverse the effects of the opioid in the event of a relapse episode. So if a person should inject themselves with heroin or take prescription opiates while they're on this medication, the naloxone will kick in and cause the body to go into immediate withdrawal. And very similar to what happens with the antabuse when the alcoholics take that medication, this will discourage them from taking heroin or any other opioids while they're on this medication, and it will make them extremely sick, nausea, vomiting, headache, body aches, flu-like symptoms. Let's see. So nursing management. Whoop, sorry guys. I need to do that. Nursing management for these patients. You're going to administer medications that the doctor ordered according to symptom management. You're going to monitor their vital signs and be an active listener. These patients need someone to talk to. They already feel like people don't like them when they come into the hospital because there's so many people that look down on patients that have drug addictions. I feel like nowadays it's very common. So people are starting to be less judgmental about it, but in times previously, it wasn't always like that. And people didn't talk about it, even though it existed. It was kind of like the elephant in the room. Nobody wanted to talk about it. So they're already scared when they come in that people are not going to treat them well because of the stereotypes that addicts have. So be understanding. Be an active listener. Advocate for your patient to enter into treatment. Talk to him about treatment. Contact the case manager. See if they can set them up with some resources in the field before they go home. So when they leave there, they're going to be successful. You're not just going to release them into the community and then they have an opportunity to reuse drugs again and not actually go into treatment. You encourage them. You support them. You encourage them to take responsibility for their own recovery. Some patients are in denial. They don't think they have an issue. If they're in denial and they don't think they have an issue, there's probably not a lot that you can do. Still educate them, encourage them, but until an addict is ready to seek treatment, our hands are kind of pretty much tied. Not only in nursing, but just as a friend. If it was your child, if it was your parent, if you were the parent of a drug addict, it's the same. If they don't want to get treatment and they're not ready, it's probably not going to happen. And then just don't be judgmental. So you need to examine your own feelings and prejudices that you have, because they can't ever come into play when you take care of these patients. And sometimes it can be overwhelming because sometimes you see a lot of these patients on the med-surg floors back to back to back, and they're not always the easiest patients to take care of because they have all these psychological issues and you don't see them in their best form. They're withdrawing off their medications. They're angry. They're sick. They're demanding. They want this. They want that. They're manipulative. They have a lot of manipulative behaviors and they try and manipulate you. And it can be very, I feel like it's emotionally draining. So you just kind of have to, you know, understand your biases regarding that and make sure that those things don't, you know, spill into the treatment that you provide to your patients. The withdrawal manifestations, again, anxiety, restlessness, aching back and legs, they're craving the drug. It's going to be progressive. It's going to it's going to continue into nausea, vomiting, dysphoria, lacrimation, severe weakness, runny nose, sweating, diarrhea, excessive yawning. They can have a fever. They can have insomnia, pupil dilation. It's significant distress, but it doesn't necessarily warrant a pharmacological intervention. You can go through the withdrawal of opioids without dying, unlike the alcohol, like we said earlier. The short-acting drugs, if you're taking heroin, the onset of the withdrawal is 6 to 24 hours, peaks in 2 to 3 days, and it gradually subsides within 5 to 7 days. Longer acting drugs like methadone, the onset is 2 to 4 days, and this subsides in 2 weeks. And it's miserable. These, I've seen it myself. My daughter actually had, I'm going to share more about her during this lecture, but my daughter spent 5 years of her early adulthood from like 21 to 25 or 20, to about 25, maybe 20 to 25, addicted to heroin. She didn't start addicted to heroin. She started because she was a single mom. She had a newborn and she was not with her daughter's father anymore. They split up. So she found herself trying to be a single mom, which isn't easy. She wound up having her gallbladder removed and one of her ovaries removed within a 3-month time period of each other. So she had access to a lot of pain medication. And with her last surgery where she had her ovary removed, she had a cyst on it that got infected and she was in a significant amount of pain. And I wasn't aware, even though she lived with me, she had continued to go back to this doctor for 6 months and get pain medication. This doctor gave her opioids for 6 months after she had the surgery, which to me is just unheard of because at some point that doctor had a right to say, you know, hey, something's not right here. This isn't normal. But she kept getting the medication. Then when the doctor stopped prescribing it to her, she needed it because if she didn't take it, then she was going through withdrawal. And when she went through withdrawal, she was miserable. She couldn't get off the toilet. She had diarrhea. She was vomiting. She couldn't show up for the baby. She was anxious. She was beside herself. Her skin was itching. She was an emotional wreck. So these patients that go through withdrawal, it's miserable. And they're not going to be in a good place. So let's talk about some hallucinogens. So hallucinogens, LSD, you've probably heard of that before, PCP, they distort the user's perception of reality and produce symptoms similar to psychosis, which includes visual hallucinations and depersonalization, which is a sense of experiencing one's own behaviors, thoughts, and feelings from like you're in a dream, actually. You can have peyote, LSD, PCP, ecstasy falls into this category. The intended effect is a heightened sense of self and an altered perception. So colors become more vivid when they're under the influence. Things seem realistic. Animals look like real animals. The symptoms of taking these medications, they're going to have increased blood pressure and pulse. They can have an elevated temperature. They're going to have diarrhea and hyperreflexia. So the psychological changes that you're going to see from intoxications are anxiety, depression. They're going to be extremely paranoid. They're going to be, they're going to feel like they're losing their mind, and they're going to have an impaired sense of judgment. So they're going to participate in dangerous behaviors like jumping out of a window. They're going to feel like and believe that they can fly. Maybe you guys have heard of that before. They're going to have impaired social functioning. The physiological symptoms, their pupils are going to be dilated. They're going to have tachycardia, diaphoresis, palpitations, maybe some blurred vision, some tremors. They're going to not be very coordinated, and they're going to have panic attacks. When they start to withdraw, they're going to have what they call a hallucinogen persisting perception disorder. So it's visual disturbances or flashback hallucinations that can occur intermittently for up to 5 years from the time that they stop taking the medicine. So HPPD, hallucinogen persisting perception disorder. It is a chronic disorder in which a person has non-psychotic flashbacks of visual hallucinations or distortions experienced during a previous hallucinogenic drug experience. And it can last up to 5 years. Then we have inhalants. Inhalants, people can get high and become intoxicated from chemicals that they put on a rag. It can be a soap rag with the compound. It can come from paper or a plastic bag, or they can take it directly from the container. The most common substances are found in gasoline, glue, paint thinner, paint spray, and then even air duster, the little cans that have the little long thing on the end that you spray on your keyboard to get all the dust. People can use that to get high too. It can cause significant brain damage, peripheral nervous system damage, and liver disease. So some things you're going to see when they become intoxicated, they're going to have an unsteady gait. They're going to have tremors. They're going to have muscle weakness, some blurred vision, some slurred speech, dizziness, acute toxicity. They can have anoxia, respiratory depression, basal stimulation, and dysrhythmias. Death is possible because they're going to have bronchospasm. They can have cardiac arrest. They can suffocate, or they can aspirate on the compound that they inhaled, or if they vomit, they can aspirate on that and die as well. Patients suffer from persistent dementia, psychosis, anxiety, and mood disorders as a long-term from using these drugs, and treatment would really just be centered around the symptoms of what they're withdrawing from. Nicotine. Many people don't think that nicotine is a drug, but it is. It's the most heavily used addictive mood-altering substance in the United States. It is inhaled. It's cigarettes and cigars. It's inhaled through the mucous membranes of the mouth. It can be snuffed or chewed. The effects of intoxication, it increases the carbon monoxide blood levels, which causes constriction of the peripheral blood vessels, which then contributes to cardiovascular disease. It can cause gastric ulcers. It can disrupt the structure of the alveoli in the lungs and cause them to become overstretched and inelastic. And that's usually, you see that usually in emphysema. The smoke is inhaled from tobacco products, which contain more than 40 carcinogenic chemicals. So tobacco has over 40 chemicals that are known to cause cancer. Consequences of smoking: 90% of people that smoke can get lung cancer. They can develop COPD, coronary artery disease, hypertension, and stroke. They can have peripheral vascular disease, low birth weight babies if you're pregnant and you smoke. And then there's just the irritation to the oral mucus if you chew tobacco. And then, of course, your risk of developing oral cancer. Oral cancer increases as well. I apologize. So environmental tobacco smoke is also known as secondhand smoke. People are at an increased risk of heart disease, lung cancer, and respiratory tract infections. If you're around people who smoke, sudden infant death syndrome is increased in infants whose mother smoked during pregnancy and after delivery. And then the withdrawal manifestations: patients are usually irritable. They're they're craving their cigarettes. They're nervous. They're restless. They have some anxiety. It might be difficult for them to sleep. Increased appetite, difficulty concentrating. They're going to be angry because they want their cigarette. And then some people even have a depressed mood. So medical management. So we want to encourage patients to quit smoking. We have to understand that relapse is common. Patients may go through a couple times before they ever become successful. Maybe they're just going to keep trying and never be successful. What works for one person doesn't work for everyone. They can do counseling with their primary care physician. You would always want to make sure they follow up. You can use behavior modification programs. Some people use hypnotism. There's pharmacological therapy we can use. They can take Zypan Zyban or Chantix, which are dopamine uptake inhibitors that help suppress the nicotine's addicting reinforcement. And then you can use nicotine substitutes like nicotine gum and nicotine replacements to avoid the withdrawal symptoms. And I've heard good things about those. I hear patients that say they took the gum or the replacements and it actually really helped them. I've heard people say that Chantix is very good, and I've heard people say that Chantix made them do some things that they weren't aware that they did, like they get up in the middle of the night and they drive cars, or they do things and then they wake up in the middle of the field, or they wake up in a park or in a car and they don't know how they got there. But some people are successful with that. So from a nursing management perspective, encourage the patient to adhere to the treatment. Just tell them that they can do it. Offer them some advice, about, starting off slow. Maybe they can't just quit cold turkey. Maybe they're just going to decrease the amount of cigarettes they take. Maybe they start with a pack a day, and maybe now they're going to just go down to 3/4 of a pack a day. And then in the next week, maybe they'll go to a half a pack a day, because decreasing is certainly better than smoking an entire pack a day. Provide them with all the educational resources they need. Contact your case managers. They can help you get information, set them up for outpatient resources, and then you want to discuss the possible side effects, because patients do experience weight gain when they don't smoke cigarettes, because then their appetite improves. So give them a strategy. Let them know ahead of time that this is something you're going to see. So maybe they're going to stop smoking, but they're also going to start the same week with a walking program. They're going to go walking 3 times a week. So then maybe they won't see that weight gain if they're actively involved in exercises. So dual diagnosis. So dual diagnosis is, you hear this a lot in outpatient rehab centers, inpatient rehab centers. Dual diagnosis means that a patient has both substance abuse and another psychiatric illness. So my daughter, Ashley, her name is Ashley, she actually went into many dual diagnosis programs. I knew that she had an underlying issue. I feel like that is a prevalent issue in the majority of people, because most people that have coping mechanisms don't turn to drugs. So I knew that there had to be an underlying issue. So she went into a dual diagnosis program, and she was able to receive treatment for her detox, treatment for her addiction, and then psychiatric therapy too, to really get to the bottom of what happened in her life. How did she get where she was? What's causing it? What's going on in her mind? So that's what we call dual diagnosis. These people go to a clinic and they receive therapy for both the addiction and their psychiatric illness. So it does offer successful treatment. It gives relapse prevention strategies. It helps them to become healthy. It nurtures them. It gives them supportive living environments. So some of these programs last up to 6 months. Some of them last 28 days, or some last 45 days, and then they can move into halfway houses where they can continue these nurturing environments that are very supportive. They're surrounded by other people who are suffering from the same thing as them, so that's not a lot of judgment there. They can help them with fundamental life changes, like being a successful, productive member of society again, helps them find a job. It keeps them surrounding themselves with other friends that are abstinent, that are in recovery, that have the same goals as them. It helps them make connections with other recovering people. It provides treatment of other comorbidity conditions. Like, for instance, maybe you are overweight and you had a drug addiction problem, and now you have diabetes, and you probably weren't taking care of yourself if you were abusing drugs. So you come into treatment, and now we recognize, hey, you have diabetes, so we're getting you caught up on all that primary care you should have had done in the past, and helping you manage your diabetes. So there we just have a nursing diagnosis. A good nursing diagnosis could be an ineffective coping related to inadequate confidence in the ability to deal with a situation. And I think that is a great nursing diagnosis, because evidently it's proven that patients that have addiction problems definitely have an inability to be able to cope with things. So treatment. Treatment is not easy to start. Recovery is possible if the addict is ready to get treatment. My daughter went through 12 treatment programs. She did 3 programs here in Maryland. She lived on the street in Hollandtown for 4 months on her own because I was not what people call enablers. I was not an enabler. At the time that she lived with me, she was 20 years old. She started using drugs. We tried to get her help. She did outpatient therapy. But I also had my younger son at home who was 10 at the time, and I couldn't allow the issues that come along with addiction into my household around him because it's not pleasant to live with someone who has an addiction. It's not easy. They're very demanding. They lie. They steal from you. It's a bad situation. But if you're willing to get treatment, treatment works. So like I said, she did a couple of outpatient treatment programs here. She wound up going to Florida because she thought she needed a change of scenery. She did 12 programs there. Was not successful. She even lived in treatment centers where patients were still getting high. You see that all the time. And eventually she wound up getting pregnant with my granddaughter now. She was 5 months pregnant, still living in Florida, still abusing drugs. I wasn't able to get her home. She wound up overdosing. They had to Narcan her twice to bring her back and do CPR. She ended up in a psychiatric ward for 2 weeks they certified her and wouldn't let her out because they said she was a harm to herself and her baby because of the choices she was making. And then when they did let her out, she asked if she could come home. I flied her home and that was it. She's been clean ever since. My granddaughter is 4. She never touched another drug after she was 5 months pregnant. My granddaughter was born perfect. She was a little small. She was a little peanut, just under 6 pounds. But she didn't have any addiction problems at all. And my daughter will celebrate 5 years clean in May. So many times she had an opportunity to engage in treatment and sometimes she wasn't ready. She was in denial. Sometimes she engaged, but she still wasn't ready. She didn't want to apply the principles that they taught her. So everybody has their rock bottom. And when they want to do treatment, they will do treatment. But you still have to encourage it. You want to put it out there for them. You want case management to come and talk to them and offer them treatment because you want them to get better. They may deny addiction. They may rationalize why they use their substances. They may blame it on their upbringing. They may blame it on their life circumstances right now. Those are all common things that you see with people who have a chemical dependence. It can be very overwhelming for a patient suffering with an addiction to deal with the notion of having to deal with this every day. And then the thought of having to never touch another drug again can also be overwhelming. And it might seem very impossible to the patient who lives day to day with a chronic mental illness. Like, how do they get out from underneath this? They disappointed their family. Maybe they've lost their family because a lot of family ties are severed during addiction. Sometimes just because family members can't take anymore. Some family members aren't educated enough to understand that it's an addiction. They don't understand the support that they have to give them. There's a variety of reasons why. But sometimes drug addicts don't think that they can come back from the situation. It's just too much for them. And they see themselves as, a terrible person who's not even worthy of recovery. So it takes a lot for them to dig deep, find their self-worth, and actually get a treatment program and, recover from drugs. Let's see. And then again, you have your 12-step programs, your halfway houses, they can help you find a job. It's all part of the process. So this little slide here just talks about, I'm not going to go over all of them, but it's the principles of the 12 steps. This model was initially started in 1949 from the Hazelden Clinic. They developed a model for chemical dependency. Originally started, the Hazelden Clinic originally started as a guest house concept for alcoholic men, and it's grown into a prevailing method for treating addiction. The program serves as an alternative for many people who have drug addictions. Instead of them going to jail, mental wards, or homelessness, they can come here and get treated. The 12-step program, you can do Alcoholics Anonymous, Narcotics Anonymous has one, there's Al-Anon, there's Alateen, there's Gamblers, and even for eating disorders can use this 12-step model. And it just encourages them, they work these steps. There's questions they have to answer, and it takes a while to get through these steps because it causes you to take a look at yourself, and it causes you to realize things about yourself that you may not feel as pleasant. And then it causes you to look at what problems you've caused for other people. Did you steal from people? What relationships have become severed because of your using? So some of these things are not easy to look at, but growth comes from them. And we all know that growth, huge amounts of growth comes from an uncomfortable situation. So my daughter actually does these 12-step programs. She still goes to meetings. She holds meetings. She goes to, what's it called? Shepherd Pratt. She goes to the jail. She treats the people, talks to them about recovery, and she shares her story. She has a lot of girls that she sponsors now. So I think that this is a great program, and a lot of people have a lot of success with it. So we talked about this again, substance abuse and treatment. We want to encourage safe withdrawal. We want to prevent relapse. There's a lot of different treatment settings and individual counseling that they can get, day programs, they can do evening programs, halfway houses, the IOP that we talked about, all that good stuff. So some things to think about for patients that have substance abuse issues. Just some pharmacological things that you would want to give. I just want to talk about these again. So for alcoholics, we told you that they have a lot of problem retaining nutrients. So thiamine is going to be a big medication that you give. Sometimes you give medications called a banana bag, and it's a yellow bag of fluids that is filled with vitamins that you give patients. Sometimes you'll just give them a tablet of thiamine. They're also going to get B12 and folic acid for all those nutritional deficiencies. You're going to use the Antabuse to help deter from drinking. And then you're going to use the Campril, which helps reduce cravings and decreases the physical and emotional symptoms that come along with when you stop drinking. And then if you have the drug addiction, the opioid drug addiction, you can use methadone or buprenorphine and the naloxone, and then the clonidine. And then you can also use something called levomethadil for heroin, which I'm not too familiar about that, but that is out there. With the methadone, you don't have to do methadone. Some people choose to do it. Some people believe that you're trading one drug for another. My daughter did not use methadone. She just thought that she would be trading one addiction for another because methadone can be abused. Some people have a lot of great success if they use it the proper way. It causes them to become contributing members of society. They're able to show up for their family. They're able to show up for their children. They're not going through withdrawal. They're not going to the street to get street drugs because they're going through withdrawal. So it's a safe, good alternative for a lot of people. If you use it in the right way, they start you off on a certain dose, and then you come into the clinic every week, and every week or every 2 weeks, they decrease your dose until basically you're not taking it anymore. That's how it's supposed to work. But it can be abused. And Suboxone too can be abused. So you just have to be careful about that. So substance abuse and the nursing process. So when you're doing your assessment, you're doing your history, you're going to look for things and inquire, do they have a chaotic family life? What kind of family history do they have? Did they have a crisis that precipitated the treatment? Maybe they never had a real addiction to drugs, but maybe the patient just lost her mother and she's all alone. And, she started using drugs because of that. Was there a huge crisis that made them start using drugs? Check out their general appearance. Do they appear anxious? Are they tired? Do they look disheveled? Is their hair greasy? Are their clothes dirty? Do they appear physically ill? What is their motor behavior? Are they able to walk? Are they uncoordinated? What's their mood like? Are they tearful? Do they express any guilt, any remorse? Are they angry? Are they just quiet and unwilling to talk? What's their thought process? Or do they believe that they can't survive without the drugs? Are they content? Are they ready to get treatment? Are they in denial that they even have a problem? Do they blame others? Well, I wouldn't be using drugs if my wife would do X, Y, and Z, or if my parents would just do this, I wouldn't be using drugs. Or are they able to rationalize they have an issue and they're ready to start treatment? Judgment and insight. The patients may have difficulty acknowledging their own behavior while using, and they might not see a loss of a job or relationship as connected to this substance use. I told you everybody has their own rock bottom. Some people are functioning alcoholics and functioning drug users. Maybe they will never use a drug. Maybe they'll only use it at night. They'll keep their job. They'll pay their bills. Their families won't know. Maybe they'll lose a job and their relationships will be strained, but they still won't make that connection until they realize that they have a problem. roles in relationships. Patients can be angry with family members who were instrumental in bringing them into treatment. So this is something that is very, very, very common. It happens all the time. It can happen if the children have addictions, they feel that way towards their parents or vice versa. Husbands and wives, it's very common initially because they don't want treatment. So they resent anyone that forces them into treatment and that does not enable them. So just to give you an example, I never enabled my daughter. I told you that from the very beginning. She was living on the streets for 4 months in Hollandtown, and she would call me and say, I'm hungry. I need food. And I'd say, then you need to get a job. If you're hungry, you need to get a job or you need to go to a soup kitchen. If you want treatment, I'll take you to therapy. She would get mad at me and hang up. And then sometimes she would just show up and she would demand food. She would demand money. And then I would tell her, no, I'm not giving you money, because I knew that if I gave her money, she was going to go back on the street and get heroin again. And I didn't want to be the one who contributed to her overdosing. And I knew that that's exactly what was going to happen. And I would just tell her that I loved her and that I would take her to rehab, but I would not be able to give her money. And she got to the point where she would say the most outrageous things to me. She would say, if you don't give me the money, I'm going to go back downtown. I'm going to have to sleep on the street tonight. Somebody's going to find me and they're going to rape me and kill me. And you're going to wish you would have gave me the money. All you have to do is give me the money. How are you going to feel when I'm dead? And I got to tell you, that was the hardest thing I ever did. I wanted to give her the money because I was so afraid that she was going to go back downtown again and that she was going to get killed, because, you know, that's a possibility anywhere if you're sleeping outside in the street at night, especially a young, beautiful, vulnerable girl in their 20s. But I never gave in. I cried myself to sleep. I cried a lot, but I never gave her the money. And I just prayed to God when she walked out that door that God would bring her back home. And he did, thank God. And she wound up getting treatment. But like I said, that resentment, she always resented me. And then it wasn't until she got clean that she said, you know, I never really hated you. I was just mad because you wouldn't enable me. You wouldn't give me what I wanted. They're very manipulative and they want what they want because they are addicted and they, in their mind, will go to any means to get the drugs. So then there's psychological considerations. They're going to have poor nutrition. Their sleep isn't going to be great. They might need some medication to help sleep. They might have liver damage. They could have HIV infection, some lung damages because they're, you know, breathing these things in and they're using shared needles and things like that. So identifying a patient with a substance abuse may be difficult. They use defense mechanisms and they're usually in denial. Patients may not even come to the hospital, I think I said this earlier, for a substance abuse related issue. They may come in for a broken leg. And this is something we see, I see this all the time. You might have a patient who comes in because they fell down the steps and broke their leg, okay? But maybe they have an underlying back issue outside of breaking their leg, and they see pain management for it, because patients go to pain management when their primary care physicians can't treat their pain anymore. Pain management assesses their need for medication and can prescribe them higher levels of medication to help keep their pain in check. So now you have this patient who has a chronic back issue. He takes a certain amount of pain medication every day. He fell down the step today. He broke his leg, had to have surgery. Now he has this acute onset pain. He comes to the hospital and we can't always get in touch with their pain medication doctor right away. We prescribe what is a normal dose of medication for someone experiencing a broken leg, which is probably nowhere near the amount that they're used to taking. So they have a tolerance to their medication. So we give them medicine for the broken leg and it doesn't do anything for them. Or they're used to taking a certain amount of medication at home, and now they haven't had it for a couple of days. So they're angry, they're in pain, and they might start going through withdrawal. So it's very important as the nurse that you recognize that, especially when they say that they see pain management. Or you could ask them, do you see a pain management doctor? If you have a patient that you're not being able to properly manage their pain, they might not tell you that. They might not even realize that they've developed a tolerance. So you want to advocate for them. You want to call the doctor and let them know, hey, you know, this guy takes a lot of oxycodone on the outside. He sees a pain management specialist, and this is what he takes every day. And once the doctors know, they can get them started on their regular dose and then give them another dose that would help for this acute pain that they're feeling. Nurses can also utilize something called the simple screening instrument for alcohol and other drugs, which is a tool that's used to identify hazardous drinking problems, as well as full-blown substance abuse disorders. This is not something that I've ever used, but this is a tool that is out there and has proven to be good. to use. All right, so substance abuse in the nursing process, we know that detoxification is priority, right? We have to get them detoxified before we can give them into any kind of a treatment program. Priorities for the individual patients are going to be based on physical needs, and some of those can include safety, nutrition, fluids, elimination patterns, and then of course sleep. So some of your nursing diagnoses that you might see, you got anxiety related to threat to self-concept, a lack of control of drug use. You have ineffective coping, there's that ineffective coping again, related to substances to cope with life events. You have insomnia related to irritability, nightmares, and tremors. And then you have risk for injury. Your risk factors are hallucinations or drug effects. You have risk for self-directed violence. Risk factors are reactions to substances used, impulsive behavior, disorientation, and impaired judgment. And then you have risk for other directed violence. So the risk factor would be poor impulse control. So when it comes to, So your outcome identification, you want your patient to abstain from alcohol and drug use. You want the patient to be able to express their feelings openly and directly. You want them to accept responsibility for their own behavior. This is huge. You might not always see this, but this is an expected outcome that you want. You want them to practice non-chemical coping alternatives to deal with stress or difficult situations. And you want to establish an effective aftercare plan, because there's nothing worse than putting these patients back into the community where there's no resources. They're going to end up on the street, possible overdosing, or they're going to end up back in the emergency room again, because there's just not enough community resources out there to help take care of these patients. So, interventions. Health teaching for the patient and the family. Teaching is just as important to the family as it is the patient. I feel like you're educating, it's the whole family together as a whole, because these patients need their family for support. So you want to educate the patient, and then you want to educate the family about what things they can look for, and you also want to educate them about the necessity for getting treatment and go into NAR-NON meetings or Al-Anon meetings, because they have to be able to understand this disease in order to properly support them. And a lot of people do not know about addiction, how it works, how it starts, how it's so addicting, so they need that valuable information. You want to include important topics for the family and the patient about how it's an illness, and that any alcohol, beer, or wine or liquor can be abused. Prescription medicine can be abused. You want to educate family members about sign of the relapse and the importance of a continued participation in an outpatient treatment program. You want to address family issues, such as codependency or that enabling, because a lot of people, especially parents, you want to help your child. That's essential to being a parent, is being able to take care of your children. And sometimes you just feel like you're taking care of them. You don't realize that you're enabling them. You want to promote coping skills that sobriety will make them, sobriety will not make their problems disappear, but rather sobriety is going to help them to think about their problems more clearly, and then provide them with coping skills to be able to be productive and handle their problems without turning to drugs. You want to help them find ways to relieve stress or anxiety that don't involve substance abuse, and you maybe working out, taking walks, things like that. You want to develop new social activities or leisure pursuits. So if you become clean, but your 5 friends that you hang around at home are still using drugs, you want to change who you hang out with. You want to start going to meetings. You want to surround yourself with people who live the lifestyle that you're living and have the goals that you have, because it will increase the probability of you staying clean. And then the nurses, we can only focus on the present. We can't go back and focus on the past. We need to encourage our patients that they can succeed, okay? And then the evaluation of the abuse treatment program is heavily based on the client's abstinence from substances. And if treatment has been effective, the result will be a more stable role performance, your patients' improved interpersonal relationships in the workforce, with friends, with family, and then they're going to state that they have an increased satisfaction with life, which is great. That's what we want for our patients. All right, elderly considerations. So approximately 30 to 60% of elders in treatment began drinking abusively after the age of 60. So risk factors for late onset substance abuse in elders can be a chronic illness that causes pain. It can be a long-term use of prescription medications. Just everyday stress from life can be a risk factor. Suffering a loss, maybe they lost their husband or their wife. Social isolation as they get older, maybe they're not living at home, maybe their family isn't close, maybe they don't have family, maybe they live in an assisted living facility and they don't have a lot of friends. Grief, depression, an abundance of discretionary time and money. Now they're retired, they don't have any time, they're bored, they're lonely. So they drink and they have money to spend on it. Patients who had drinking problems earlier in life may experience a significant period of abstinence and then it resumes again later in life. That's seen very often. And then physical problems associated with substance abuse develop more quickly in the older adult, especially if they have, if their overall health is compromised by other comorbidities. So community-based care, same thing for them. There's outpatient treatment. There is freestanding substance abuse treatment facilities, inpatient and outpatient. You have your AA meetings, your self-help programs. There's aftercare programs where you can do like the halfway houses. You can do individual or family counseling, and then you can always go to your local clinic or your primary care physician's office. So mental health promotion. Public awareness and educational advertising is huge. Our mental health programs in the United States are suffering. We don't have enough promotion or public awareness about mental health issues, which leads to addiction to alcohol and drugs. Early detection of older adults with alcoholism is extremely important. The College Drinking Prevention Program is a program that was sponsored by the government, and it was designed to help students avoid the predictable or expected binge drinking that's common in USA colleges. So 1,825 students die annually from alcohol-related issues. 599,000 students are unintentionally injured while under the influence of alcohol, and 400,000 students report having unsafe sex, and 100,000 of them reported even being too drunk to know if they were able to consent to sexual activity. So that program that they developed for colleges gives a lot of resource to the colleges and educates a lot of younger adults in that age category. Substance abuse in healthcare professionals. This is huge. This is something that I learned about in nursing school, and I was, a little reluctant, and I didn't think that it was something that probably really happened a lot. And I've been a nurse now for 6 years, and I can tell you that I've seen it happen at least 10 times. And I've seen 6 of those people lose their jobs. It's a real thing. It can happen with physicians. It can happen with dentists, nurses. They all have far higher rates of dependence on controlled substances such as opioids, stimulants, and sedatives than any other professionals of comparative education achievement. So as nurses, we have an ethical, legal responsibility to report suspicious behavior to your reporting supervisor. It's a sensitive, difficult situation, and we may be hesitant to report suspected behaviors for a multitude of reasons. We might find it difficult to believe that a trained professional would participate in such behavior. It might be a friend of yours who you adore, who you're really close with, and you don't want to turn on them. You might feel guilty thinking that you're falsely accusing someone, or you just want to avoid conflict altogether. You just don't even want to be involved with it. Those are all normal things to feel. Some general warning signs that healthcare professionals will exhibit if they do have a problem: their work performance can become poor. They can have frequent absenteeism. They might be presenting with unusual behavior. They might have slurred speech, and they might isolate themselves from people at work because they don't want people to know that they're using drugs, okay? So other things you might see in the workplace is the hospital might start noticing incorrect drug counts associated with certain nurses. There might be reports made by patients of ineffective pain relief. You know, the night shift nurse might come in and say, you know, Mr. Jones, how is your pain today? And then he might say, actually, it was great all day, but now that hip is really hurting. I need to take some pain medication. Can I have it? And she'll say, well, you know, you just had it 2 hours ago. I can't give it to you. And then the patient will be like, I didn't take my pain medication 2 hours ago. I never took it at all. So things like that make people question things, and then they have to dig a little deeper. They may have excessive controlled substances listed as wasted or contaminated in the Pyxis. So every medication that needs to be counted, if it's a controlled substance, generates a report. It generates a report that you took it. It generates a report if it was something that needed to be wasted, if you wasted or if you didn't waste it. And it keeps just a report of how many things you are wasting. And it generates reports that go to your managers, and they serve as flags. And sometimes it doesn't mean anything. It just means that you had 5 patients that day that all had hip replacements and they all got IV Dilaudid. And that's exactly how it happens sometimes. But it's not always that case. Sometimes it is that nurse that's taking medication and taking them and then wasting them, or not wasting them, and they're taking the medication home with them. They might have unexplained absences from the unit. They say they're going to get a coffee. They're gone for a half an hour, 45 minutes. They come back without a coffee. You don't know where they've been. They might arrive early to work, or they may leave late for work, or they may come to work for no reason at all. You might see them on the floor when they're supposed to be at home or in the med room or something like that. Nurses, the thing you have to remember is that nurses are just like any other member of society, and they deserve the opportunity for treatment and recovery, and reporting suspected substance abuse can be that crucial first step into getting your coworker the help that they need, because just like everybody else that has a drug addiction, they might be in denial. They might be too far in. They don't know how to get out. They're embarrassed. They're afraid of losing their license. They're going to lose their kids. They're going to lose their home because they're losing their livelihood. And, you know, sometimes I've seen employees who have drug issues and the hospital works with them. You know, ultimately you do lose your job, and sometimes they turn it into the Maryland Board of Nursing. And then, you know, sometimes you can have the opportunity to get your license back in a year or two if you're clean. Sometimes they'll place you in job positions where you don't have any access to medications. Like maybe you work in a dialysis clinic where you don't give medications, pain medications, things like that. So always, if you see that, just remember you have an ethical legal responsibility to. And then do you really want this nurse caring for patients? What if your mother was a patient in the hospital and there was a nurse that was high at work and they were taking care of your mother? Wouldn't you want a coworker to report them and help them get the help they need? Whenever I find myself in an ethical situation like that, that's exactly the stance I take. Well, what would I want if it was me? Or what would I want if it was a family member of mine? And that is exactly what I would want. I would want someone to get that person help so that they didn't provide the wrong care or hurt another person. So we talked a little bit about this earlier. There are self-awareness issues. You have to examine your own beliefs, okay? You have to know how you feel about certain issues, how you feel about alcohol, how you feel about drugs. For someone who doesn't have any experience with addiction, and they may be very judgmental. They may think unthinkable things about people that have addictions. I've seen it in the workplace. They're not very understanding. They're not very tolerant. I, on the other hand, have always had a different approach because I have dealt with addiction. So I feel like I'm a little bit more understanding. I'm capable of looking at that person and knowing that's somebody's baby at one time. You know, this was their little girl. This was their little boy. They didn't always have this issue, or, you know, this is someone's mother. You know, I feel like I've always been good at that, but I have to take a look at my own self-awareness about issues that bother me so that they don't spew into my practice and cause a negative outcome for the care that I provide. You have to understand that substance abuse is chronic. It's a recurrent illness, just like heart disease or diabetes. There's going to be relapses and remissions, and it doesn't mean that they can't get clean and stay clean. It just means that sometimes they fall off the wagon and they just need to get right back on again. And then you have to remain objective and reasonably optimistic. And I think that is it. That is the end of this lecture. So just a little bit more about my daughter. She is clean. I don't know if I said that earlier. I forgot how much I said. She's been clean for almost 5 years now. She has her daughter. She has custody of her other daughter back. I wound up getting custody of her first daughter when she was 2 because she was actively using and she was living on the streets. And she has her daughter, both of her daughters with her. She actually works for a recovery company. She works in human resources. She's been there almost 2 years now. She has her own car. She has her own apartment. She's in a great relationship. She's probably going to be engaged soon. They're looking to buy a house. And she had many, 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 many relapses. And I always thought that her reality was probably going to be death. And I had planned her funeral. I knew I took out life insurance on her. I just knew that that was going to be her reality. But it wasn't. So you never know. As long as people are in treatment and they're trying and there's breath left in that person, the probability of recovery is there. So always just try and remember that, and always just try and be non-judgmental because those patients really seem to need that. So this was a great lecture. I really enjoyed teaching you guys this. If you have any questions, I will be on Zoom with you guys tomorrow after your exam review, and we can go over any questions. All right, have a good day, guys.